years that allergic rhinitis and bronchial asthma frequently coexist together had led to the concept that these seemingly separate disorders are manifestation of the same disease expressed in either upper airway or lower airway. The atopic diseases of the nose and lungs are in fact related to each other and coexist in many patients. In some patients, rhinitis predominates, and in other patients, asthma is undiagnosed or subclinical. In others, it is reversed, while in many, both are clinically expressed. As a result, new disease terminologies has been introduced. وقعدوا يسموا بقى اللي هي شركة الطيران المعروفة ليونايتد ايرواي ديزيز أو allergic rhinobronchitis or combined allergic rhinitis and asthma syndrome اللي هو الكراس. And here we're gonna use the name كراس. هتكلم دلوقتي مش هتكلم كتير يعني، بس هتكلم على الايفيدنس ان في الكومبايند ازما راينايتس allergic rhinitis asthma syndrome، واتكلم على الاندرلاينج ميكانيزم leading to كراس with the impact that treatment of either upper or lower respiratory tract has on the other، واخيرا عن clinical approach to patients with كراس. دلوقتي هتكلم عن الايفيدنس ان في حاجه اسمها كراس. evidence anatomical وphysiological. الاناتوميكال انه two airways has a common respiratory epithelium and the common mucosal susceptibility to disease. As we know, the respiratory tract is lined from the nasal ossia to the respiratory bronchioles by ciliated epithelium. However, there are differences, particularly in the physiological mechanism leading to reduction in airflow in both. وهنقول ده الكلام دلوقتي. In the upper airway, obstruction results primarily from vascular engorgement of the mucosa, while in the lung, bronchoconstriction, مش vasculature هنا بقى. Bronchoconstriction is in smooth muscles, which is not present in the upper airways. The upper and lower airways are functionally linked. يعني stimulation of the nasal mucosa may result in changes in bronchial hyperresponsiveness. It is speculated that the nasal and sinusal receptors stimulation affects trigeminal nerves with parasympathetic fibers via the vagus nerve, resulting in subsequent changes in the bronchomotor tone. Clinically, rhinitis is often defined as a risk factor for development of asthma. دايما بيقولوا كده يعني، حتى البيشنتس يقول لك يا دكتور طب انا لو عالجت حسيت الانف دي هتتصلح، هي كله من مناخيري، يقولوا كده كله من مناخيري. This definition is not completely accurate since rhinitis may also represent an early stage of KARAS. It has, however, been shown that persistent rhinitis is a risk factor for asthma, even in the absence of any markers of atopy. The coexistence of sinusitis and asthma, especially in children, is known, and sinusitis and/or adenoiditis have been shown by endoscopic assessment to occur in more than 50% of children with asthma. Infected sinuses are reservoir or proliferating bacteria. ده أحد الاقتراحات, and are frequently associated with worsening asthma. Endotoxins from the cell walls of gram-negative bacteria have potent pro-inflammatory properties, and inhalation of endotoxin has been shown to induce airway narrowing and hyperresponsiveness in patients with asthma. Regarding the epidemiological point of view, clinical observation during the 1960s showed that there was an association between allergic rhinitis and allergic asthma. In a study of the effectiveness of specific immunotherapy, 50% of control group of children who received no immunotherapy بيجي لهم asthma in few years. A survey of 99 patients followed up for 10 years after initial diagnosis of allergic rhinitis, allergic asthma, or both showed that 32% of rhinitis patients develop asthma. 50% of patients with asthma alone developed rhinitis. The underlying mechanism leading to KARAS. What is the underlying mechanism? في physical mechanism in the upper respiratory tract functions as a physical filter, resonator, heat exchanger, and humidifier. so that inhaled air arrives into the bronchi at temperature of approximately 37 degrees centigrade and almost completely water saturated. Inhaled particles more than 5 to 6 microns are retained in the nose. Failure of the some upper of the lower respiratory tract. And another mechanism is the allergen exposure. The development of either upper or lower airway symptoms can depend on the particular allergen to which the sensitized individual is exposed. يعني لقوا انه السيزونال allergens زي الجراس والتري بولنز can cause intermittent symptoms. For example, intermittent seasonal allergic rhinoconjunctivitis. ده الايه الجراس والتري بولنز. انما الالرgens which are present year round such as animal danders and house dust mites are more likely to cause persistent symptoms of asthma and or rhinitis. In part, this may be related to the size of the allergens. احنا كلنا عارفين ان البولنز are generally approximately 5 micron in size and are likely to be filtered in the upper airway, causing allergic rhinitis. However, the house dust mites and pit allergens are smaller in size, approximately 1 micron, and readily penetrate into the lower airways. Mouth breathing, when nasal obstruction is present, exclude the upper airway filter, that increasing the possibility of lower respiratory tract symptoms. The other mechanism is the immunological mechanism. Inflammation of the nasal and bronchial mucosa plays a critical role in the pathogenesis of asthma and rhinitis. Both upper and lower airways demonstrate a similar inflammatory cell mucosal infiltrate, although differences exist in the extent of inflammatory indices in allergic rhinitis and asthma. The immunopathological response, chronic allergic inflammation, is similar in the upper or lower respiratory tract infection, respiratory tract airways. It involves Th2 lymphocytes, mast cells, basophils, eosinophils, نفس الكلام بالظبط والIgE والcytokines such as interleukin 5, 4, and 13, and rantis, chemical mediators of inflammation such as histamine and leukotrienes and adhesion molecules. In a sensitized individual, IgE binds to the tissue mast cells and circulating basophils, which are then activated following allergen exposure to release histamine, leukotrienes, and other mediators. This activation results in immediate nasal symptoms of itch, sneeze, and rhinorrhea, neurally mediated and nasal obstruction vascular in origin. In the lower airways, the immediate symptoms are bronchoconstriction, hypersecretion of mucus. Modeling exists microscopically in most asthmatics. However, it may not be obvious in rhinitis, where the epithelium remains intact in case of allergic rhinitis. And now, the impact of KRAS on the treatment of either the upper and lower respiratory tract has on the other. What is the similarity in treatment? The treatment of combined allergic rhinitis and asthma syndrome should be directed to the underlying inflammatory process common to allergic rhinitis and asthma. The differences in the adrenergic control of the upper and lower airways differs. The vascularity of the nasal mucosa means that symptoms of nasal blockage can be readily altered by alpha adrenergic agonists, which are vasoconstrictor. إنما the smooth muscles of the bronchial wall relaxing effectively with bronchodilators as beta-2 agonists. And the intranasal glucocorticoids improve allergic rhinitis symptoms and also improve symptoms of asthma and bronchial hyperactivity. H1 antagonist antihistamine used for a seasonal allergic rhinitis may also improve concurrent mild seasonal asthma symptoms. ولكن ما فيش significant improvement of the pulmonary function occurs. عشان كده احنا ما بنعترفش قوي بالانتيهيستامينز in treatment of asthma. Antibiotic therapy for sinus disease in children has been shown to improve lower airway symptoms. Improvement of asthma has been shown after sinus surgery in patients with either nasal polyposis or rhinosinusitis and asthma. الحقيقه انه ده بنلاحظه فعلا انه some patients undergo surgery to the nose regarding the polyps. الازمه بتاعته بتتحسن فعلا بعد الاوبريشن. Care should be given when prescribing topical steroids عشان ما ازودش الدوز بتاعته. However مهما زودت الدوز بتاعت الانترانيزال or the inhaled steroids برضه it will be with less side effects than the parenteral steroid. Allergen immunotherapy اللي هو الالرجي vaccination is an important therapeutic tool for management of CARAS and it is indicated in patients with concomitant rhinitis and asthma. Immunotherapy can modify the natural history of the disease and maintains its effects for years after discontinuation. Studies have shown that montelukast, a potent and selective blocker of the senile leukotriene 1 receptor, can improve symptoms of both allergic rhinitis and asthma. Many studies have shown that omalizumab, a humanized monoclonal substance anti-IgE, is very effective in treating of both allergic rhinitis and asthma syndrome. All patients presenting with allergic rhinitis and or sinusitis should be evaluated for the presence of asthma by history with chest examination and if possible by assessment of pulmonary function test before and after bronchodilator. Basically, patients with asthma as the prime presenting disease should be asked about intermittent or persistent nasal symptoms. Uncontrolled allergic rhinitis can lead to a worsening of coexisting asthma. Prompt and effective treatment of nasal disease can have a marked beneficial effect on preventing the development of asthma and on existing asthma symptoms. Take-home message: the most individuals with asthma has allergic rhinitis. Allergic rhinitis is associated with development of severity of asthma. It is likely that treatment of allergic rhinitis with medications or allergen immunotherapy can significantly reduce asthma morbidity. Current guidelines recommend an evaluation for allergic rhinitis in all patients with asthma, and thank you so much.